get everyone, I won't go back through my name and my position. But to talk to you all. But to me, health equity, simply as I like to put it, is meeting patients where they are. So I came to this definition, a little bit of background about myself. I am a sickle cell patient, so when I was born, my mother found out that I did have sickle cell disease. And so I'm no stranger to the healthcare system. I'm no stranger to having received help from outside entities. And David mentioned the Martin Center Sickle Cell Initiative is one of those entities that has been present with me throughout my life. And they are what gave me my passion to feel for healthcare. And as the definition I have for health equity is meeting patients where they are, whether that's at level one, which is simple education, making sure the patient understands exactly what they may be going through, or whether that is providing them with emergency assistance, food services, transportation to doctor's appointments, what have you. So I just am a firm believer in the patients at level one that you meet them at ground zero, or if they're at level four, that you find ways to meet them there as well and ensure that they keep elevating.
Thank you. Well, I agree with everything that these ladies have said on this panel. My name is Pamela Clark. I'm the Minority Health Initiative Director at Community Action of Southern Indiana in partnership with the Indiana Minority Health Coalition. I have been in public health for about over 25 years. I have owned a nonprofit for 14 years addressing chronic diseases. And also, my mother passed away from pancreatic cancer, and I left that position and went to the American Cancer Society. And I was an associate director for the Mid-South Division over their outreach program that addressed breast cancer prevention. So I've been in this, on the battlefield, as our pastor says, for a long time because chronic disease has impacted my family. I've had 3 siblings that have had cancer, my mom and my nephew. So to me, health equity is what allows us to be our mother, our sister, our brother. If you have your health, you have everything. I'm able to go to work. I'm able to play with my grandkids. I don't have to worry about a copay. If you have your health, and it's also about quality health care, not just getting health care. We want to make sure that our family health centers, when we call on you guys, call your legislators, we want to make sure that you do just that. We want to make sure that we continue with our breast and cervical cancer program here in the state of Indiana. And there's other issues that we can address as well. But we want to make sure that we are a voice. And I feel that I am that voice for those who are not at the table. When you see me, you see my community, the black and the brown that feel that they don't have a voice. But I want to share a quick story. And that is, we were doing door-to-door canvassing a few years ago, and I had a lady who was talking, you've got to go where the people are. And she said, I've had a lump in my breast for about 3 months. And I'm like, you're right down the street from the Family Health Center, why don't you go? Well, they don't treat me right there. So, long story short, I did lose track of her. But I did get her some information, and I shared that information with the executive director. Because that's also, if we're going to be a voice, we might as well go in and sit at the table and address those issues that we hear in the community. So that's one story, but I also want to quickly share a quote from Martin Luther King. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And I believe that today.
Ladies, thank you so much for sharing your backgrounds and your poignant definitions of health equity, and really to your service, lasting legacies to your communities. We talk about health equity definitions as if it's a static thing, right? But we're really working towards health equity ongoing. So help us visualize. When we get there, what does that look like, and how do we get there? So when we look at that, the Centers of Disease Control and Prevention defines health equity as health equity is achieved when every person has the opportunity to attain his or her full health potential. We'll discuss that. And no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Tara and Anne both discuss that specifically with examples. And that Health equity inequities are reflected in differences in length of life, quality of life, rates of disease, disability, and death, severity of disease, and access to treatment. We really addressed that in the social determinants of health component of our earlier discussion. So if we say we want to achieve it, these definitions don't help us get there. It just says what it is, what we do. So through the work that you all have done, being the pillars within your communities, and literally being the representation of this is how we do it, share your wisdom with us. How do you actually get there? What are the things we need to be doing? So Pam, with your background in the school systems in Jeffersonville, every time I have a Zoom with you, there's a chalkboard in the background and kids coming in and out. So how does that occur within the school system? What does that look like for us to teach our youth to help them visualize that future so they can be part of it?
Well, I think you really need to share the history. We were talking, and that's the history of the Tuskegee experiment, the history of Henrietta Lacks. We've got to share how did we get here? We got here because of, but we should not be here today. America is the richest country, and we're still here talking about health equity. So what some of the outreach that I do is prevention and intervention programs in the schools. And we have a program called Community in Schools. We go in with our 3rd, 4th, and 5th graders and we talk about nutrition. And we also talk about physical activity. You'll be surprised at how many kids do not know how to do a simple sit-up. So I have a good time with them. I enjoy it. I'm honest with them. I bring in little treats that they're not familiar with. But I think it starts in the elementary school. And also I think tobacco programs need to start in the elementary schools. Vaping is a big issue. I know in our schools, we just had a community discussion on Thursday evening, and we talked about what is it that we can do instead of suspension and expulsion. Kids go home and say, we've got to get in the schools and partner with our schools. We've got to be that resource. We've got to go into schools and let them know that we are available. We're available. If we can't do it, Tara, won't we go in and find somebody to do it? So we want them to know that we are here for them. We connect with them. We just want to be that resource. We want to save our children. We don't want those generational chronic diseases that's carried on from your great-grandmother to your grandmother. We don't want that. We want to break that cycle. And how do we break that cycle? We break it through education. We've got to educate. We've got to start early with kids because kids are listening.
And with that messaging, Pam, kids absolutely are listening, and it's not always a statement written on a chalkboard delivered by a teacher, although we absolutely need to wrap around our services and support our teachers. That messaging has to come in all sorts of form and fashion, and one of my favorite stories and ongoing interactions is I've never physically ever sat with Tara Morris in a conference room. I've met her at a barbecue, at a basement of a community center. I met her at many faith-based organizations. I even met her one day when she was corralling some children at a daycare, and she said, Sonny, change the address, come meet me here. And we were literally having a walk and talk with kids, walking around, and I'm like, this is great. I like being active. So as the queen of community outreach and messaging, since it doesn't happen in the conference room, ma'am, what are your words of wisdom of how do we get to health equity as a community? How do we improve our messaging to the community?
Again, community dialogue. And you truly have to go where they are. Because if you don't, you miss them. I've been doing this now 28 years, as Pam still came right behind me. But in doing so, you have to know what the people want. And I had to really just jot this down in a way that knowing what's going on in our local community as well as what's going on at the state level, but knowing who and what they're doing when it comes to communities, we can review that. When we review it, it's kind of a question. Avoid people. And then know who is doing what. And when you say community dialogue, community dialogue from the youngest to the oldest, community dialogue within the organization, and what they are doing. And because we're at this point now, when we want to talk about health equity, we all have to kind of be on the same page and know your population. And when you call it together, know who's sitting in that audience. Because if you don't, you're going to be right over their heads, and we need to keep it simple. We need to keep it simple, and we need to continue to dig and, like they say, reason with, and pull people to respond and document. Because one thing for sure, like Sonny said, that is the only way to actually get to some type of resolve when it comes to health equity. And Pam alluded to it well, from the local level to the state and to the federal level, we need to know who our local legislators are, our local municipalities, what they want to support this. And when we think about our partners, who they are, what they're doing, and again, I say avoid replicating what's going on. You want everybody together so we can dialogue. And talking about it in conclusion. Different council, the council said, we've got like 2 or 3 going in Alfred County. Why don't we have 2 or 3? So we all get together and talk, because the first thing people look at when I think about what it is I do, what is my mission, where is my passion, I need everybody to come together. And I'm sorry, I do a process of elimination.
She's really good at it, respond to her emails.
And our mission here is to think about people when it comes to healthcare, accessibility, quality of healthcare, and we stay true to ourselves and to the people that we are actually acting as our voice, as that true advocate. And that's how we help. We get to this whole thing of health equity, because it's nothing to do with this new. And we're still pushing for our minority ethnic and the underserved ones. And I think someone had alluded to this very bit. Health providers is more into a clinical setting. I came over to Chicago, I came over in 89. And coming from Chicago, there were community health centers every year. And I lived on the way to our park area. And came here and people went back to Chicago for health care. Our family did. And then to say in 1994 it was spearheaded by gentlemen with us, and now it has grown from an apartment in Elkhart, city of Elkhart Public Housing, to having 5 different sites. That's progress. And Elkhart County is urban, rural, you name it, it's just broad in that understanding. I think we're going to have one of the largest Spanish-speaking populations. And as we continue to serve, we have to follow that protocol of who we are, what we do. And let's just build a point to have that conversation again. But we're still undefeated.
Tara, so well said about the continuous painstaking work of outreach, dialogue, community collaboration. But I look at it as anytime we reach out, anywhere near northern Indiana, you are always part of the conversation because you built that reputation to say, I'm an advocate. And that's incredibly important as we look at so much to do, having clarity of role and responsibilities and purpose, and most importantly, accountability to ensure that those things are done. Equity in the community context requires so much collaboration, so much feedback, so much support, so much context in conversation with the community. But health equity also has a very interesting process-driven component where in disease state management, especially in diseases like cancer, we have whole systems, literal software systems, processes within the hospital, processes within outreach to other organizations to support the wraparound care for a cancer patient, that we almost approach health equity in systems and medical as almost like a gap analysis, like a review of what do we need to input into process to ensure that there is equity for those that have to experience this disease state. So in cancer, where it is so process-driven and so innovation-driven based upon that disease state, we've made so many leaps and bounds, and that's a good kind of model almost to say we've got these very clear-cut ways that we walk a high-risk patient and a patient currently going through cancer. So how do we, in your lifelong passion in cancer support, or how do we continue to support that? How do we evolve some of those processes into all of health equity?
Well, this is a big topic, right? We could probably brainstorm and sit here close to the morning on this particular topic, but you know, the healthcare systems are trying, right? We have, in most hospital systems now, we have patient navigators, nurse navigators, right? So that's how some of the people that we're calling on. That's how a lot of the health systems have decided to course correct on that particular problem. But we still have a little bit of ways to go, right? I think not all hospital systems have this. And to be quite honest, not every hospital system has enough navigation, right, to get people through the process. Because if we're not paying attention, we'll lose people. I think Pam was telling a story where, we have to follow up. It's really hard. Even just walking through the hospital is a hard thing. So most hospitals do a good job having volunteers to direct people. So these are the kinds of things that they're doing. If we copy on a larger scale, cancer has a lot of cancer navigators, but not every disease state has a navigator, someone to answer your questions and walk you through the process. I think we still have some things to go. I think some of our physicians maybe could use some help in health literacy, but if we could have more navigators, that would help, because not every patient who comes through and has been diagnosed with cancer understands the terms. Do we all understand the terms? I don't know. I'm a counselor by trade, right? Do I understand every single term? And there's new terms all the time. Is there someone there to explain that? Because these are, and sometimes, think about this, patients are like, do you want chemotherapy A or do you want chemotherapy B? Are the physicians and nurses and even the navigators being trained on cultural things, right? Not everyone can do cancer A because you're going to be down for 6 weeks and not be able to get out of your bed and be exhausted. Did somebody stop and say, hey, can you take that much time off work? Not everybody can do that. What if you're an hourly employee? Is someone really asking those questions? Those are the things that I think even inside the healthcare system we have to do a little bit better on. Is anybody asking, maybe you're the person in your family that does the child care after school, and everybody and their family's income depends on you. You can't be down every day. So are the doctors, when they're asking patients to make a choice between chemotherapy A and chemotherapy B, are they doing a good job thinking about the culture and what that, I think someone mentioned individualized medicine. Are we really thinking about the person and what they need? I think we also need to work on screening. I think hospitals are doing better. But Neil did a brilliant job about even the problems when you're getting the screening truck out. Not everybody can get it, right? So I think that was a great thing, so I won't go over that. Clinical trials are really important to me. I see Lisa Hayes in the audience here. It's something Pink Forever is really passionate about. I think it's really important, too, to make sure we have representation for everyone in clinical trials. So how do you know that medication that's the standard for everyone here in Indiana, how do you know it works for everyone if not everyone was in the clinical trial? And so how do we do this? So I think we still have a little bit to go, and I can't neglect, I am a counselor to talk about mental health. Suicide rates in cancer patients are 2 the average population? Are we supporting people enough that they go, oh, wait, I am gonna be okay, I am gonna make it through this. And if we need financial incentives for the hospitals to do it, the statistics are out there. You save like $100,000 per patient if you get the proper treatment for their depression and anxiety. That's a big number, so if people are like, oh, we can't pay for that, well, we could. If they were getting proper treatment, we'd save some money, and that can pay for the program, right? So these are things, and then the follow-up. Follow-up is really important to me. I've had so many people over the years that were like, it might be better for my family if I die. They're like, well, this is going to be really expensive. How are we going to pay for this? I don't want to leave my family with all of these medical bills. So a lot of hospitals have responded by having financial navigators, but usually they only have one person for all of those people coming through. So I think the hospitals are doing a good job, and I think they've got some models maybe we could copy, but I think you still have a few gaps in things, right, where we could do better, even in the hospital system. And then who follows up with those people who just decided it's too hard to get to treatment every day? Does anybody follow up and go, hey, he's missed his last 3 chemotherapy appointments? Maybe we need to check and make sure there isn't a barrier that somehow we've missed and they can't be here. So I think there are this model of navigation that they put in place, financial navigation that they put in place is great. They're trying to do the screenings. So I think hospitals have come a long way in some areas, but I think we do have a ways to go at looking at each person who sits in front of you and gets treatment as an individual and what do they need. I like brought up boxes. Some people maybe even need more than 2 boxes. If they're caring for and supporting their whole family, they need 3 boxes or 4 boxes, right, to get them up to be equal to everybody else. So those are some of my thoughts after 24 years working with cancer patients and their family members.
Laura, thank you so much. This well-said model of navigation is a systems level, all hands on deck, understanding where we hand off and ultimately who's accountable for the next step. And I challenge really our community teams to think through, do we have a model of participation? Do we really have that lead navigator, as Laura called, in the community context? Sometimes that's a person. We rightly have shown and shared with Tara and Pam in their many years of work within the community. But shouldn't that be a role? Shouldn't that be a resource? Shouldn't that be a reimbursed designation that we really say and point to and say, yes, this is the role that we all expect to understand that is carrying that community collaboration work, and that here is the opportunity for that to be a profession, a career. And so I'm really excited that we're waiting for our community health worker model discussions later on today in just addressing how are we going to really step forward as community health workers. It's not a new role, but new focus and funding and support is now being directed to that long time honored community leader that stepped up out of the passion of their own hearts and out of many times their own pockets. So Laura, please.
I so love that term. I so love the term navigator. And when I think about Indiana Minority Health Coalition, and today we have 21 local coalitions. And starting back in I actually started in 1994, came to Coalition in 1995. That's what we were charged to do. And we didn't get paid. It was what our community needed. That's what the patients needed. They needed to be empowered to be going and challenge the doctors to give me my 10 to 12 minutes. And we continue to do it today. And that doesn't happen all the time. So today we're in a position to say, we need to be paid. or those community health workers that need the certification and license approval from Medicaid in order to move forward. We need to be paid, because this was a work that had been going on. And we had to, from the grassroots, raise it to this level. And I can say we weren't initiators in the Minority Health Board. We stand. And so here we are, and you have to know your community. You have to know what's going on in that community and where those disparities lie in those pockets of individuals that are servants. You got your cancer, your heart disease, you got diabetes, you know, I just rounded all up to chronic disease, so that's what the programs that we utilize. And also our community labeling, which is now our community health workers. So we need to be paid. And it takes a true passion and desire for that type of work. And it's something you just can't get out of the book. You can't. And I had a quote here, and probably as many of you have probably got my email and everything, or my letters. And it comes from, and I quote out in Lester and Mark, there is absolutely no way to save people from the things in their eyes. They must gather the courage to do it for themselves. But how do we get courage? We have to inform, we have to educate, and show them how to advocate for themselves. And I'll say it again, we're still not there yet. And we do need to get it. We all, navigators, community health workers, which you have to get done. And I would say that's probably one of the challenges that we're facing today, of those individuals who are coming to the forefront, but knowing.
Thank you, Tara. I agree with you 100%. But I'm from Jeffersonville, which is across the bridge from Louisville, Kentucky, so it's a metropolitan area. We have our issues, big city issues, just like Indianapolis and Louisville. But I worked on a project years ago when I worked for the American Cancer Society, and it was a colorectal cancer project with Dr. Jones, and it was to find funding for free colorectal cancer screenings. And the problem was, people could not get to the prep that needed to be distributed. So we identified that later after we set up all these clinics throughout Louisville. We were like, okay, how do they get the prep? How do they get to the clinic? That was an issue. We thought about the bus. That was an issue. People didn't have access to, didn't feel safe walking in their community to get to the bus stop. So I said all of that real quick to say that where we live, work, and play does determine our health. If you live in a community that is not safe, your kids are not going to go out to play. You're not going to go out for an evening stroll to walk your dog. You know, you can't go down the street to pick up some fresh fruit and vegetables. But it's just important to know that the work that we do is innovative work. I always come up with, and Tara knows this, I always come up with something intentional, but fun, but make sure the message is there. Not only that, I have a group that I call my crew. I can call on these 6 organizations anytime, and they are key in our community, and they show up. We can't do this work by ourselves, but people trust us. So, and I also would like to share a quick story. When my mother was going through cancer, they gave her 6 months to live. She lived 4 years. At the time, I had my nonprofit, and I had a doctor, an oncologist on my board. So I went to her. She was a Black female. So I went to her and I asked, could you be my mom's doctor? And she's like, yes, I would be honored. But I learned so much of the terminology because of the field that I'm in. Everyone doesn't have a Pam in their family. So we've got to be that voice. We've got to be that voice. We've got to train, you know, caregivers, families that are taking care of their families. We've got to train them on how to talk to your doctors. Don't be embarrassed if you don't know something. When my husband was diagnosed with lymphoma, I called, I got the information, I read the information. Did I understand all of it? No, but I asked questions. A lot of times the people that we serve are too embarrassed because they don't understand the terminology, the medical terminology. All I know is that I have sugar. So what do I do? What do I take? I can't afford it. I can't afford my medication. So we want to make sure, we can't reach everybody with our nose. We will go over no make goes. And we will do the best we can to connect you to resources. We go out and seek and look for resources and what's going on in the community. So that's what we do. And it doesn't stop at 5 o'clock.
No, it does not. I remember years ago, a hiccup that happened that we'll never be mentioned again. But Pam took her crew, brought her crew, and in one day, we held a block party and media there. So thank you, Pam. You know what incident I'm talking about. That was a long time ago, but I'm still hot about it, so. Pam, I want to just take a moment and share with our attendees virtually and our attendees here on site, really the crew context. And I really want everybody who is in the room and virtually to think about who's in your crew today. And write these terms down and think about a person that is this term to you. On your crew, who's your financial go-to? Who's that person that helps with budgeting, finding dollars, understanding costs of things, looking at the market? In your crew, who's that medical person? That person that can showcase and share the terminology, guide you to other medical professionals and resources that understand that specific disease state, process, etc. Who's your advocate? Is it your legislator or is it someone else? And if it's not your legislator, write them an email about what you do, who you are, what your organization does, because they're here to serve you and your community. Who is your community gatekeeper? That person you can call and you know 30, 40 people show up. Who's that person for you? And then who's your health system's administrator person? Not your clinician, but that health system's administrator person that after hours can say, let me tell you how it really is, and here's how we navigate that. Who else do we need on our crews, ladies? Anybody else that you can think of? Tara, please.
Listed numbers, but they're really in your group when you have yourself.
Mm-hmm. Yes, and you can speak text and they respond,
And
yes.
it's 12 o'clock at night, and I need for Dr. Ahmed I need this right now, can you help me? And whoever those community health workers in New Terms today, and you can pick a phone, say, such and this, I need you to be there in the morning at 7, and guess what they said? I'm on. But just like Sonny listed, it does. Everybody has local legislators. That's what bills are sent off and passed or denied. And you have your local as well to have their cell phone number and email in your phone in your life. And they listen. They do. But on the local level, just like Sonny said, you need that from the medical professionals right down to your ladies, community ladies.
I'm your public health officer. He can text me, I can text him. During COVID, we wanted to set up a clinic in a African American church. I had not reached out to him, but he called me on a Saturday morning and said, Pam, I have some vaccine left over. Do you know of a church? And I contacted our executive director. He contacted the pastor of his church, and we screened 40 people that Saturday. That's when we did 40 shots that Saturday. So it is about who can I put on speed dial? Who do I have that relationship with? Who can I be honest when I know someone in the community is using your services and they're not pleased, but this is what's going, this is the word, what's going on in the community about your agency. You need to be aware of that. This is what they're saying. So,
Thank you so much, ladies. There is so much prevention knowledge that's also being shared here as we talk about community interaction, community dialogues, etc. With NCREI being at an academic institution, with teaching future generations, we're really looking at how is NCREI an intervention to ongoing health equity process changes. And Camille, how do centers like NCREI continue to act as that direct intervention towards health equity?
So within the NCRI specifically, we focus a lot on assessment and advocacy. So one of the first things I did within my role is we started conducting COVID-19 research to assess within the community what needs that they needed as far as health literacy was concerned, education was concerned, and remaining vigilant within the pandemic that we're all still in, even though it's not receiving as much notable coverage as it once did. So we're firm believers in assessing the community before you serve them to really give them the quality care that they need and not what you think that they need. And as far as advocacy goes, advocacy is, I was being hard on advocacy even in elementary school before I did self-advocacy. So it's something that I definitely carry with me within my work and of course put within the NCREI. For example, with our Public Health Summit series, a great portion of that is a guided panel discussion just as this. However, it's from actual patients on whatever disease topic we're covering at the time. And I'm a firm believer in no one's a better advocate than the person living with said thing that needs to be advocated for. So that is very prevalent within the NCREI as well. And lastly, primary prevention. A lot of the time, especially within minority communities, screening isn't necessarily a thing, or we don't really learn about a disease until we have to live with the disease. And now it's a question of, well, what do I need to change in my quality of life in order to sustain it? Instead of figuring out, well, I know this is genetically predisposition in my family. What can I do to lessen the risk of me being exposed to this disease? And of course, all things aren't, avoidable. However, establishing those great lifestyle choices beforehand within that primary prevention effort can prevent secondary and tertiary intervention being necessary.
Absolutely, and it's so powerful to have those stories from our community of those that have self-informed, willing to educate, and then taking it on a bigger platform to advocate. Many times when we see health systems marketing, right, it's this kind of generic, unknown, vague patient. But there's real patients. There's real yous and needs and meals and stories of, I want to care about this person. I want to understand what that journey is. And I think we need to be more directional, intentional, and also appropriately from a disclosure perspective in asking our patients, our survivors, and the individuals that are the representation of our communities to share their stories and not make something up and take new stock images. And, I love our graphic designers out there, but we have real people to share their real stories. So thank you for that. I just want to reiterate from the NCREI perspective what Camille shared. They're doing COVID-19 research. Please connect with them on data. We have this wonderful Indiana Together We Will grant that is funded through the CDC and is administered out of the Office of Minority Health. Folks, we have a 74% return and please reapply rate for lack of data. Sources are out there. We have to be community collaborators in identifying what those sources of data are and including that data to really showcase, not only do we know these are the needs of the community, but we can show we know that these are doing for the community. It's wonderful. Ladies, you guys are doing incredible work. I feel humbled on the stage to be with you all. We have talked about so much about your change agency work in health equity, and I've kind of like written a whole thesis here in notes. Leaving here today, though, Tara said, make it simple. So, what do you want our audience to take away from you specifically in what you are doing? And accountability goes both ways. How they can not only understand, be informed of what you are doing, but also help you in what you are doing. As every single person here wears multiple hats as an individual part of an organization and leading their own passion projects. So, what are you doing that you want the audience to take away, and how can they support your work?
Within the NCRA, I would say just supporting us in our primary prevention efforts that we have ongoing. Whether it's simply signing up to receive our weekly newsletter, where as of right now, September is actually National Disease Literacy Month. So we are actively educating on different diseases that are prevalent within minority communities. As of right now, within our newsletter, so just remaining educated in that aspect. On Saturday, October 22nd, we have our second annual community access fair. Of course, public health and wellness is a sector in that, and we are actually going to have an on-site vaccination clinic here for those who receive vaccines, regardless of legal status, documentation status, criminal justice status, what have you. Those who attend will have the opportunity to get vaccinated, whether they need COVID vaccine, boosters, flu, pneumococcal pneumonia, what have you. We're providing that as well. We're also cultivating a Lunch and Learn series, which is just an hour series monthly that will highlight one health topic, and of course will be provided in the lunch part. But just bringing in someone within the community or a health expert that can educate those within the community that would like to join us on certain health topics.
Wonderful. So, Public Health Summit, Lunch and Learn series, and an upcoming October 22nd community resource fair that has all sorts of wonderful events and services, direct services. Thank you.
So, and you guys speak here today, this something that is, you know, because you can see from this academy and empowering you to talk about the health care. It's still not gonna happen overnight because we're not there yet. But also take advantage of, you know, when we think about the equity, when we're doing that data, let's look for veterans data, the approach that they have in place, but also we need to just kind of foster meaningful engagement with our community and organization and diverse leaders that are among us. So we need to engage them and be public responsive outreach and reduce stigmas, you know, and those stigmas that are associated with race and ethnicity. Because we all are looking to that point of health equity and to ensure that everyone is has health insurance or some neat way of getting it. But we need to inform them because it's out there. So, you know, and get to know your community. And again, get to know those that actually face the loss.
This has been really enlightening and very educational, and I appreciate these ladies sharing. But I will follow up with that COVID-19 research because I think that's going to be some good information for our community. And that'll be a great opportunity to get your community involved in a community discussion. So, but some things that we're doing down in Southern Indiana, we just finished up our Hispanic celebration where we served over 141 kids and 98 adults and provided some screenings, and we also gave out bicycles, and just, it was fun but very educational. We are also supporting and have a kickoff for Count the Kids this month. with an organization in New Albany, Indiana. I'm working with a couple of doulas, and keep in mind, I really don't have funding for doulas, but that never stopped us before. So I have a couple of ladies that are going to be doing 3 workshops focusing on breastfeeding and infant mortality. So that's going to be interesting. And that is something new that our agency is doing. We're going to partner with our Head Start program and Head Start families. We have a kickoff for that on the 18th of October. Again, I call my key partners. We come in, we set up, and then afterwards we'll start those 3 sessions for our doula classes. The other thing that we're doing, we're partnered with Purdue Extensions, and there was a grant for BIPOC farmers. I brought that grant to our agency. We are now the lead agency. We have submitted the grant. It has to go through the USDA and then through IDOH. So hopefully we'll hear something soon. There's only going to be 5 grants in the state of Indiana. So I'm really thankful that to have a good partner that called on me and said, Pam, let's have a discussion. We didn't know what we were doing, but we knew that we needed to address this issue and try to bring it to Southern Indiana. But there are 19 counties that we'll be working with. So we're excited about that. As Tara said, health equity is everybody's problem. It is everybody's concern. It impacts all of us. The stories that I shared with you about my family being diagnosed with cancer and the doctor who met me on the other side of the door and said, when is the bill going to be paid? Well, are you asking everyone about that? My mother was on Medicare. She was in her 80s. So, those are the kind of things that we have to address. As Tara said, we need to advocate. We need to be that voice. So I'll continue to work and do the work that I'm doing. I enjoy it. I have a passion for it. One day, we hope all of these chronic diseases will be out of the job, Tara. We'll be gone.
Pam, you are the consummate learner. Pam started with, here's what I learned, what I'm going to do. And then she went into, here's what everybody's helped with. Pam, my dear friend, please look at Indiana Together We Will, INTogetherWeWill.com for your doula funding. Please, please. Do you not worry, I have my checklist I will be contacting you.
I have some asks for those of you that are here today. I would like, if you could, if you're working with the Hispanic Latin community, if you could refer to our Latino Family Night. They meet this. They come together, they have supper, they have support group. It's all in Spanish, so it was difficult to find someone to lead that, but we've got it up and running. We have ability to do a little bit of counseling in Spanish, so get on our website, make a referral to that if you can. If you need more information, Carissa rates Hispanic family. She's our marketing director. Those are real people, by the way, on our signs. Those are our real participants that come to programs, so she makes sure that happens, so you can sign up for her for that. We do have a patient assistance fund. It's for gas to get to treatment and for food. So you get a Kroger card and a gas card. So make a referral for that program. I would also ask that if you meet someone that's having trouble navigating their cancer journey, that you reach out to Nina Coley, Nina Wave. She is our new community navigator. Instead of expecting everybody to come to our building, we're sending Nina out into the community, and she's meeting one-on-one with people, getting them hooked up with services. So talk to Nina if you want her to come and speak to a group of people. She'd be willing to do that. So she's fabulous. She's almost been here a year. Woo, Nina. So talk to Nina. And Sunny, we're talking about data. So we got into some initiatives where we're trying to get some data. We're doing, Nina and Carissa found someone to be trained to help other African Americans if they have questions about clinical trials, right? Somebody who's already been through that can pave the way for someone else to come along. So they can call, they can ask questions. Right now, this is in a research phase, and if you make a referral and someone says, hey, I have some questions about clinical trials, I'd like to talk to that person, definitely a phase, this is the research phase. Okay, there's a little bit of compensation for that. We're also doing a study on treatment adherence. I did not know and understand that 75% of breast cancer patients, after they're finished with their treatment, don't continue to take their post-treatment medication for that 5-year, 10-year time period, whatever the doctor said. So we're involved in a study with an electronic pill box that sends you text messages that, please take your medication. So we need people to sign up for that very desperately. And there's competition for that as well. So we're trying to do some things to produce that data and say, hey, this is indeed, we have to do this. There needs to be funding for this. So we're working on those. But the biggest thing you can really do for me today is if everyone in this room would go back and talk to Carissa at the table and pick up the flyers for these things and sign up for our email list, that would help, just that one thing, so that if you're out and your friend or your neighbor or someone in your community or someone in your faith organization gets cancer, and you're like, I'm on that mailing list, you know what? They're having a great workshop, and they're having dinner too. Let's see if there's a virtual option, because we can't drive there, but maybe we could walk in. Or maybe we want to go over and maybe we want to have dinner at Cancer Support Community and actually shake that doctor's hand who's coming and volunteering this time. So for me, these are great initiatives, but I think the thing you can do here today to make a difference is get on the mailing list and help us out. Any way you can by spreading the word, that's really what we need, so people know that we're here and that we're trying to help to the best of our ability. And if you have to have some extra time and you want to come for a tour, Nina, Carissa, or I would be happy to give you a tour too. All right, so help us out. We're really trying to get almost everything we do to have a virtual option, because transportation is real here. So please help us by spreading the word.
So I have signed up for the newsletter. It's very well formatted, intentional, succinct information delivered right to your desktop. Thank you, Carissa, one marketer to another. And really well done. I really appreciate the time and just the sharing, but most importantly, your legacies of work. So thank you all. And audience, we give our panelists a round of applause.